And with that, I call upon Dr. Namrata Shri. Dr. Namrata, please come on that dais. She's going to present the poster on hospital-based study on combination of brinzolamide timolol versus dorzolamide and timolol. One second, Namrata, just give me a second. So before that, we just call upon again, that's the last call for the presenters. That's Dr. Anu John. Is he there? No. Dr. Tanmay? No. Dr. Anujit is not there. And Dr. Priya Sharma. Okay, please start now.
Of disorders characterized by chronic progressive optic neuropathy resulting in characteristic appearance of optic disc and a specific pattern of visual field defect that are frequently but not invariably associated with raised IOP. Normal IOP ranges from 10 to 21. Ocular hypertension treatment study and the collaborative initial glaucoma study suggest that 50 to 75% of patients require combination therapy at some stage of the disease and may need 2 or more drugs to achieve target pressure. A fixed combination has potential advantages like no risk of drug washout, reduced exposure to preservatives, reduced side effects, reduced treatment cost, and better patient compliance. Previous studies like Mani et al., Holo et al. Have found that BT and DT have almost similar efficacy at lowering IOP. The purpose of this study was to compare the efficacy on IOP reduction and patient compliance of brinzolamide 1% plus timolol maleate 0.5% fixed combination and dorzolamide 2% plus timolol 0.5% fixed combination in a hospital-based population with primary open-angle glaucoma or normal tension glaucoma. This was a prospective randomized controlled clinical study. 86 eyes of patients with primary open-angle glaucoma or NTG were randomized to receive BT or DT, 43 eyes in BT group and 43 in DT group. Inclusion criteria were male or female of 18 years of age or above, clinically diagnosed POAG or NTG who were uncontrolled on a single or double medication other than the eye drop to be studied. Exclusion criteria were any active ocular disease other than POAG and NTG that would interfere with the study outcome, sensitivity or allergy to any component of the either study drug, pregnancy, planning a pregnancy or breastfeeding, functionally masked visual field loss, ocular surgery within the last 3 months, concomitant uses of ocular drugs, active systemic disease or plan to change the ongoing systemic treatment that might affect the IOP, diabetic retinopathy were excluded. The IOP was measured at baseline 2 weeks, 1, 2, and 3 months. The main outcome measures were the mean change in IOP from baseline at every visit. Secondary outcome was the tolerability. In results, we have mean reduction of IOP was 26% and 44% at 2 weeks, 26%, 45% at 1 month, 27%, 46% at 2 months, 28% and 46% at 3 months with BT and DT respectively. Tolerability and compliance was without any adverse effect was seen in 83.72% in BT group and 32.55% in DT group. Tolerability of BT and DT with reference to the adverse effect shows that there was no adverse effect in 14 patients in DT group and 36 patients in BT group. Ocular discomfort, pain and blurred vision was more in the DT group. Reducing the amount of drugs by including more than one medication in a fixed combination will reduce the side effects and increase compliance. Although tolerability is identified as a barrier of compliance, issue of efficacy needs to be carefully investigated before investigating the patient's drug tolerability. In our study, we found that both DT and BT significantly reduced the IOP at all study visits, but there were lower mean IOP for DT than BT at study visits that was statistically significant at 2 weeks. Regarding the tolerability, because the beta blocker component of the 2 carbonic anhydrase inhibitor containing fixed combination products is identical, any dissimilarity is due to the pH. DT is having the pH of 5.65, whereas BT has physiological pH. Concluding my study, the present study suggested that BT and DT provide effective IOP lowering. Both fixed combination provide effective reduction, but patients are more likely to achieve lower IOP with DT group. With DT, tolerability of BT was better than DT. And DT is more appropriate therapeutic choice for IOP lowering than BT for patients in need of one or more than one eye drops. Thank you.
Thank you. It was a nice presentation. Just 2 questions from my side. You said that the more lowering of IOP was achieved in DT group, right? Yes. That's dorzolamide you're talking about. Yes. Any particular reason for that?
Significance?
Yeah.
Was it statistically significant?
It was significant.
And any particular reason to that?
Ma'am, it was just
The type of glaucoma was same in both the groups.
Yes, ma'am.
So you said that the amount of pressure reduction, which was more in that particular group, that had the same type of glaucoma as compared to that BT group, right?
Yes, ma'am.
So no particular reason for that.
No, ma'am. We just observed this finding in the group that we gave the DT eye drop. More IOP reduction was in every visit more in the dorzolamide group than the brinzolamide group.
Okay. And
But it's at 2 weeks, no? So what was the duration of
Ma'am, 3
follow-up?
months.
Huh?
3 months.
3 months.
that is the longest follow-up you have done. That
Yes,
is up
ma'am.
to
For
3
this
months.
study, 3 months.
Okay. And what about the tolerability? You said that BT had kind of discomfort more.
No, less discomfort than DT. We found that the patients given brinzolamide-timolol combination were more comfortable with using the drugs.
And but you said about the blurred vision. What was that?
That was observed in few patients in the dorzolamide-timolol combination group.
The blurred vision.
Yes, ma'am.
What drugs were actually used? You need to mention there the brand. Misopta, what were for the brinzolamide timolol? What was used?
Ma'am, we had 3 brands. Oh,
You were too quick. I could not notice. So what was which brand did
Ma'am,
you
it
use?
was
The
not
brand
quite-
matters.
Oh.
So your study, what brand? So it's a generic drug you're using. It's
Yes,
not a.
Actually, ma'am, we did not do a brand-based study. We just did the combination of the drugs.
Yeah, but
So,
what I'm saying
but
is
brand matters. So, how much the IOP control? You can't just use different drops for different patients. You should maintain the same. Did you maintain that? Which company brand did you use?
Ma'am, we did not specify that.
No, when you do a study, you need to mention that. That is very important.
I think what ma'am is trying to say is that sometimes, innovator versus generic or brand versus non-branded may make a difference to the outcome. Sometimes in terms of tolerability, though the molecules are still the same,
Same.
within that, but and there was, I suppose there was no financial disclaimer to the study, or was it sponsored by any?
No,
Was completely
not
run?
sponsored, no.
Okay.
The study results
How did
will
you
be
choose
affected by the brand of the drugs. So that is important. You need to mention.
How
that.
did you decided which drug to be used?
Sir?
Which brand to be used? How to decide? Was it generic or there was some particular
All of
brand?
them use the same brand. That is, or different companies. That again will affect the study. That's not the right way to do the study.
Okay.
So, ma'am is right, absolutely. So, how did you use the drug? Did you use any particular brand or you use any generic drug?
We used that combination we specified. We did not specify the brand.
But, ma'am, I will disagree with in the sense that ultimately it's the molecule that we're studying. So, ideally, they should have used, let's say, a generic in all things. I mean, it becomes very difficult to then, it becomes very, let's say, the financially implicated kind of a study. So ideally, yes, it should be generic only. I mean, it has to be the molecule that we're studying, not the preparation. That it may make a difference, I agree. But then regarding study, what matters is the study of the molecule, the combination of dorzolamide and brinzolamide and timolol.
Yeah.
So, I may disagree with you, ma'am.
Actually, there are certain brands which are more effective among the generic group.
Right. But
So,
here we're studying the molecules.
yeah, studying the molecule, but how it's been prepared, it varies. So certain
I agree
brands
with
might
ma'am.
be
Ma'am is
more
right.
effective.
She
So
is
you
right.
can't give one person one brand and then the other person.
Yes.
Just the combination
Yes.
drug is not
You
what
have to
matters.
use the same brand.
The
Yes.
same brand should be for all
Yes. That's true.
the two groups should receive the same brand.
That you
So
can't
was
change.
it done? That's what I want to know. So she's not sure.
She is
about
right. Actually, then you have to use the same company brand. Yeah, the combination
and
has
you
to
need
be
to
same.
specify that
Yes.
because a person who reads the paper should know which brand was used. So the results all can be skewed because of that.
Okay.
The company has to be same. I mean, either it's generic or same company. That's very important. You can't use one company this and one company that. That's not
Ideally,
done.
whatever studies done elsewhere, so it's all with the FDA approved drugs.
Yeah.
So they are again mentioned. So what is the brand name of that drug? So here again, so it's not wrong to do with generic drugs, but you would
Mention,
need to
yeah.
specify.
But it needs to mention. That's true.
So thank you very much.